This is Miss Jane Doe. She's a 37-year-old female. She is a established patient at the office. She has a history of hypothyroidism, takes 100 mcgs of Synthroid daily. She also has stage 1 hypertension that she's been diagnosed with, managed with lifestyle and diet modifications. States at time of initial diagnosis, 130s over 90s. Lifestyle and diet modifications have shown home readings of 120s over 80s, which is concurred with office data. Current blood pressure reading 126 over 84. Patient states that 2 weeks ago she had a 3 to 4 day onset of rhinorrhea, non-productive cough, right ear pain. From what she describes, it appears to be a facial pain at the time of onset. She points here and says it hurt here. She did not have any chest pain at the time, no palpitations, but she stated she presented to the emergency department at the 4-day point of symptom onset because of an acute increase in shortness of breath that she had not had previously. Emergency department elected not to do blood studies, but they did conduct a chest x-ray from her report, strep test, and fourplex testing for COVID, flu, and RSV. Chest x-ray did not demonstrate any acute abnormality. Strep was negative. Fourplex did, however, demonstrate a COVID-19 infection. Patient was encouraged to conduct a regimen of every 3 hours, alternating acetaminophen 100 milligrams and over-the-counter ibuprofen 600 milligrams. She states compliant with their recommendations. She says that at about 1 week point, she had full resolution of symptoms. However, 3 days prior to this PCP office appointment, she says she had this tingling sensation on the right side of her chest about the mid-sternal point. She said it resolved intermittently. She had no exertional chest pain, no shortness of breath, no cough. She didn't feel like her heart was palpitating. She said it's just kind of been constant since it started, but it intermittently increased in pain, even at rest. Patient called the office yesterday, made an appointment for this morning. Patient says that this chest pain is mostly concerning to her because of family medical history of an MI. Says her mother died at age 54 from an MI. She doesn't know her father. She doesn't know any other medical history of her mother. She has no siblings. She has no known drug allergy. Further review of the patient's symptoms, I asked her about belly issues. She said no abdominal pain, no NVD. I asked her about her GU symptoms. She had no dysuria, no hematuria. Again, she states her symptoms resolved related to initial presentation, no cough, no rhinorrhea, no ear pain, no sensation of a postnasal drip. She doesn't have any eye pain. She doesn't have any eye drainage. On physical exam, the patient does demonstrate a reproducible chest pain on the right side of the chest. There's no reproducible chest pain to the left side of her chest. However, it points rib connections 4 through 7. She does have reproducible pain. I pressed and she indicates an electric-like pain that goes about to the mid-clavicular line at that 4 through 7 point. It doesn't shoot to her arm, but it does when I push, she says it shoots out. Further physical exam findings, she's an overall well-appearing 37-year-old female. She's non-toxic in appearance, no acute distress. Again, she says resolution of her symptoms. I checked her ears. Her TMs are clear bilaterally. Pearly gray appearance. There's appropriate light sign, no bulging. Her external auditory canals are without erythema, without exudates. There's no significant cerumen accumulation. Her conjunctiva are clear bilaterally, no injection. There's no drainage from the eyes. The nasal turbinates are not without swelling. There's no nasal obstruction. There's no postnasal drip when I examine her mouth. There is no tongue swelling. Oral mucosa is pink and moist. The nasal mucosa is also pink and moist. I listened to her chest. She has clear lung sounds bilaterally, no wheezes, no murmurs, no wheezes, no rhonchi, no rails. Her chest sounds are clear. There's no murmurs, no rubs, no gallops. She has appropriate rate. She has appropriate rhythm. Office data showed an initial rate of 99. I palpated her radial pulse. She appears to be about 85, 90. I took it over 15 seconds, multiplied it times 4. She's not tachycardic. Because she's a post-viral state, I did check her belly. No palpated tenderness in all 4 quadrants, no acute bowel sounds. She has no report of generalized myalgia, generalized weakness, generalized fatigue. Because the patient's in this post-viral state, my most likely differential would be a musculoskeletal type chest pain post-viral state or a costochondritis in a post-viral state because of family medical history. Um, MI uh, and STEMI are on my differential. P is very low on my differential. The patient is not on POBC. She does not have an IUD. Her contraceptive method is barrier. She has a single partner, which she reports consecutive use of condoms. She's not a non-smoker, non-drinker, does not report any illicit drug use. I think the patient would benefit from an EKG in the office. I did discuss this with her. If you approved it, we would conduct the EKG. We don't have any point of care testing at this office, so no blood work is indicated at this time for the episodic visit. She just had a COVID, she just had a strep, flu, RSV, all things that would indicate any viral or bacterial testing. She doesn't have any kind of purulent production from the nares or from the chest. So I don't think this is an infectious state. I think most likely the patient is presenting with a post-viral chondritis or musculoskeletal chest pain state. The current recommendations are to continue with OTC, acetaminophen, and NSAID use. I would encourage the patient to continue that current use for eventual resolution of symptoms. I did encourage her not to take too many NSAIDs for the risk of GI issues. She's taken 600 OTC ibuprofen. She says she's taken 3 pills, and I asked her if she had the pill bottle on her. She didn't. I said if she asked if she had a picture. She did. She showed me the picture. They're 200 milligram tabs. So she's taken 3 of those, and then I asked her about her acetaminophen. She did have the Tylenol bottle, and it's the 325 Tylenol. So she said she's taken 3 at a time, so 975, almost 1,000 Tylenol. So she's following concurrent use as recommended by the emergency department, and she says it does help. If I want to feel like watching her over time for the eventual resolution of symptoms is important. For further follow-up, I did recommend that the patient evaluate herself for any exertional chest pain. Any exertional chest pain, I recommended immediate follow-up with the emergency department. The patient is saying that these symptoms are not exertional, so that further affirms my stipulation that she is not any kind of acute coronary syndrome. I told her to follow up with the office at her regular scheduled appointment, call the office for any acute changes, and if you have any questions or any recommendations that I can follow up on or do better, I really appreciate it. Thank you for having me, and I look forward to feedback.